the sun rises over the San Joaquin Valley, California. Big news! Our program has relinquished our affiliation with UCLA and we have decided to join USC instead. Just kidding. April Fools! Today is April 1st, 2020. This week, the United States became the country with the most coronavirus cases in the world, with over 213,000 confirmed cases, probably more by the time this podcast is over. COVID-19 continues to spread around the world, Italy being the country with the most casualties, with over 12,000 deaths. It is difficult to talk about anything else, during these times of turmoil. You may ask yourself, is this the result of a spontaneous viral mutation? Is it a conspiracy against capitalism? Are extraterrestrials involved? Was the virus created for economic reasons? There are many theories. You can draw your own conclusion. What we can't deny is that this pandemic has touched every aspect of our lives.
Welcome to Rio Bravo Q Week, the podcast of the Rio Bravo Family Medicine Residency Program, recorded weekly from Bakersfield, California, the land where growing is happening everywhere. The Rio Bravo Family Medicine Residency Program trains residents and students to prevent illnesses and bring health and hope to our community. Our mission is to seek, teach, and serve. Sponsored by Clinica Sierra Vista, we are providing compassionate and affordable care to patients throughout Kern and Fresno counties since 1971.
When there is a crisis, let your heart pray, but let your hands work. John Kramer.
That's a wonderful quote. And that quote actually reminds me of another quote, which is pray as everything depends on God and work as if everything depends on you. It was attributed by Ignatius. Religious freedom is great, isn't it? Today, our guest is Gina Cha. Gina is known as the intern at Care Medical by her inpatient team, and I'm glad that she accepted the invitation to come and talk to us about a relevant topic today. Thank you, Gina, for coming. As you know, we have 5 questions that we ask in this podcast to all our guests. So let's start with question number 1. Tell us who you are.
Well, hello everyone. My name is Gina Cha, and yes, I am called the intern. I was born and raised in a small town about an hour northeast of here called Porterville. I am also Hmong, and I have 7 siblings. I went to the American University of the Caribbean on St. Martin.
And Gina is a wonderful resident. I'm glad that she's here today to talk about a very interesting topic. So, Gina, tell us what you learned today or this week.
Well, how about I present a case that I've actually personally experienced this week at the hospital?
Sure, let's do it.
Well, I had a patient that was about in her late 20s, and she had no significant past medical history. She presented with yellowing of the skin for about 1 day. Her associated symptoms were a little bit of nausea and some right upper quadrant abdominal pain. By the time we saw her in the ED, she had since resolved these symptoms. Because of her continual yellowing of the skin, she went ahead and presented to the ER.
Okay, and she said she also had some nausea and vomiting, you told me, right?
Yes, that's correct.
Yeah, so that's a interesting presentation because it's a yellowing of the skin and abdominal pain, so you already had some differentials in your mind. So with the history that you obtained, what do you think?
Well, so because of the yellowing of the skin and we were thinking jaundice, some of the stuff on our differential diagnosis has to include why there was an increase in bilirubin. So because of her age, we had to think about, does she have chronic alcohol use? Is there alcohol use that's causing liver damage? Or does she have anything like hepatitis viral infections that's causing damage to the liver? Or does she have something like gallstones that can block bilirubin excretion? Or does she have something like hemolysis, something that's causing her red blood cells to be broken down?
Yeah, so those are a very good list of differentials. We have to remember the triad of Charcot, which is jaundice, fever, and usually with rigors, and right upper quadrant pain, right upper quadrant abdominal pain. When the presentation also includes low blood pressure and mental status changes, it is known as Raynaud's pentad. So that's an important reminder. And so Gina, how do you narrow down your differential in this case?
Well, in this particular case, the most important thing to help kind of narrow down our differential was to really take a detailed physical exam. So by the time we saw the patient, she was in no acute distress. She did have some skin jaundice throughout her skin, but no scleral icterus that we noticed. And so the most important thing to kind of rule in our differential diagnosis and to rule out some of the differential diagnosis is to really focus on the abdominal exam. So when we went ahead and looked at the patient, she had positive bowel sounds. She was non-tender to light palpation and non-tender to deep palpation. And she also had no guarding, and she had a negative Murphy sign.
Okay, Murphy sign, what is that?
Well, Murphy sign is a technique that is highly sensitive for the diagnosis of acute cholecystitis. The way we perform this is we have the patient lay down, and we go ahead and press on the patient's right upper quadrant abdomen and have them take a deep breath in. So we're essentially feeling for the gallbladder, and by the patient taking a deep breath in, it really allows for the gallbladder to descend and be palpated.
So the same principle applies when a technician is performing a right upper quadrant ultrasound. If there is pain during the ultrasound with inspiration, it is a positive Murphy sign as well. So tell me, what's cholecystitis?
Well, in short, it is an infection and inflammation of the gallbladder that can be quite serious if left untreated. Some of the complications that the patient can develop are symptoms such as fevers, chills, an increase in the white blood cell count. And if left untreated for a long time, it can also cause perforation of the gallbladder and sepsis.
Yeah, and ultimately death. Right?
Mm-hmm, exactly.
The patient can die from it. So cholecystitis is actually the infection, but not everybody with gallstones has cholecystitis.
That is correct.
Okay, that's very important to remember. What are other things that you looked for in this case, Gina?
Okay. Well, in this patient, we had kind of our clinical picture, and we had our laboratory values that we also had to take a look at. So one of the most important laboratory values in this particular case is taking a look at the comprehensive metabolic panel. We're essentially looking for elevated liver enzymes, and that includes an elevation in their AST, ALT, ALK phos, and of course we have to take a look at their total bilirubin. Interestingly enough, there was a meta-analysis of 22 studies that revealed that there's an elevated serum bilirubin, has a sensitivity of 69% and specificity of 88% for the diagnosis of stone in the bile duct.
So an obstruction of the bile duct. So infection and obstructions are the most common complications of gallbladder disease. And with those findings, were you able to narrow down the diagnosis, Gina?
Well, with her clinical picture, her laboratory values, it kind of indicated that there was a blockage somewhere in the biliary duct, as the patient did have right upper quadrant pain that she kind of described as colicky in nature. She, based off of her CBC, was not anemic, so that kind of helped rule out that there was any hemolysis. The hepatitis panel was negative, so she didn't have any viral infection. So it was kind of safe to say that she probably had a blockage somewhere. But to be sure, we also went ahead and obtained an abdominal ultrasound, and we had noticed that the patient had a dilated common bile duct that was measuring approximately 8 millimeters in diameter. A common bile duct is a tube-like structure that carries bile from the liver to be expelled to the intestines. So any common bile duct that is measuring more than 6 millimeters with an elevated serum bilirubin is highly predictive of stone obstruction, which leads to our patient's diagnosis called choledocholithiasis.
Choledocholithiasis. Wow, that's a mouthful.
Yes, it is. However, if you break it down, you can understand why it's given its name. Chole stands for bile, doco stands for duct, lith stands for stone. So choledocholithiasis is essentially a fancy way of saying stone in the bile duct.
Good. So tell me a little bit about the anatomy of the biliary tree.
Okay, so when we take a look at the biliary tree, it is made up of the left and right hepatic duct, and it comes together to form the common hepatic duct. This also meets with the cystic duct, which makes up the common bile duct, and which essentially meets with the common pancreatic duct and drains into the duodenum via the ampulla vater.
Okay, so what's the difference between choledocholithiasis and choledocholithiasis?
Well, choledocholithiasis is a stone in the gallbladder, and choledocholithiasis is a stone anywhere in the biliary tree, out of the gallbladder.
Oh, okay. That's very, very important. Very important to differentiate both of them because the treatment is going to be different based on the location of the stones.
Exactly.
And so, why is this important for you, this knowledge, Gina? Why is that important for you and your patients?
Well, Dr. Ariaza, I have a question for you then. Do you know the number of Americans that have gallbladder disease?
I don't know, 1 million?
Well, according to the National Health and Nutrition Examination Survey, there are over 20 million Americans who reported that they either have gallstones or a history of cholecystectomy. So it's very important to kind of recognize the common symptoms and symptoms of anyone with gallbladder disease. It's important to recognize those so we can properly treat them and properly work them up and give them proper management.
Oh, that's very good. Yeah, I can name like 10 friends of mine that had a cholecystectomy.
Oh, wow.
So, by the way, the beep that you hear in the background is just a background noise because we're in a clinic. We're in an actual clinic, so we're not going to edit that beep. So, just to explain why you hear that sound. There's different beeps and different alarms in this clinic. Okay, and then, so yeah, I was telling you that it was very common. I can tell you like 10 friends that had cholecystectomy. So, and Gina, how do you get this knowledge?
Well, so most of my knowledge I actually get from my clinical experience. I'm much more of like a hands-on learner, so obtaining information from textbooks is a little difficult, but what I would do is during my rotations, in my surgery rotation or in my GI rotation, I saw a lot of these cases that we just talked about, and it made it a lot easier to kind of go home and review the literature. So that's how I do. Yeah. Sorry, everyone.
Yeah, sorry. Okay, that's excellent, Gina. That shows that you are really a hands-on learner, and then you go back and review the books, and that's important also because the experience has to be, combined with the review of the literature.
Yes, I agree.
So, where do you get this knowledge from?
Well, there's multiple resources that we kind of have access to, including American Academy of Family Physicians, and a lot of the times easy access that we have is up to date, or also when we're reviewing for STEP or our boards, we are also using USMLE questions as well. For this particular case, I was able to review articles by Aranian Mustafa and Salem Zako, as well as Afdael Nazam, and these are all articles that are up to date.
And you can see the details in our website. And by the way, Gina passed her step 3.
Yes, I did, everyone!
Yeah. Congratulations.
Thank you, Dr. Ariaza.
So, thank you so much, Gina, for talking to us about this yellow skin disorder. And I hope you guys enjoyed it. Anything else that you want to add?
No, everyone, keep learning.
Okay. Thank you, Gina. Bye-bye.
Thank you.
Speaking medical. The word of the day is amblyopia. This is a non-lazy way of saying lazy eye. Amblyopia is the functional reduction in visual acuity caused by abnormal visual development early in life, up to age 6 years. Amblyopia is decreased vision in an eye that otherwise typically appears normal. Amblyopia is the most common childhood cause of monocular vision loss. In Greek, amblyopia means dullness of vision. It occurs in 2 to 6% of all U.S. children. Causes of amblyopia include strabismus, which is the most common, followed by refractive amblyopia, and then deprivation amblyopia, such as that caused by a scar or mass, which is the least common. Methods of treatment include patching, atropine, or Banter filter applied to the glasses lens of the good eye, and depend on what type and how severe the amblyopia is. If there is suspicion for amblyopia, don't think, "That's all Greek to me." Place pediatric ophthalmology referral because amblyopia is nearly irreversible by 9 years of age.
Hi, this is Dr. Rava on our section Spanish por favor. This week's Spanish word is angina, which is spelled the same as angina, although angina in Spanish means tonsils. People usually use this word in its plural form anginas, referring to both tonsils. This word comes from the Latin root angina, which means strangling, choking, or narrowing of the throat. So you can have a patient coming to you saying, "Doctor, me duelen las anginas," and it literally sounds, "Doctor, I have angina pain." If you hear this, don't panic. Your patient is not having a heart attack. He or she is telling you that they have a sore throat. Now you know the Spanish word of the day, angina or anginas. All you need to do is to assess your patient's tonsils. Have a great week and take care.
And now, for your sanity.
Hi, Lisa.
Hey, Rava, want to hear some jokes?
Sure. What is it?
All right, you ready?
Yes.
All right. Did you hear about the optometrist that fell into his lens grinding machine?
No, I did not.
He made a spectacle of himself.
Oh my god.
You got one?
Did he really? I have another one. Lisa, does an apple a day keep the doctor away?
I don't know, does it?
Only if you aim it well enough.
Savage.
I know.
All right, I got one more. Why did Dracula go to the doctor?
I have no idea.
He couldn't stop his coughing.
Okay.
During this episode, we talked about choledocholithiasis. Remember, think about the liver, alcohol, gallbladder, hemolysis, and infections when you see a yellow skin patient. A millimetric stone obstructing the biliary tree can cause big trouble if it is not diagnosed and treated on time. Don't forget the medical word of the day, amblyopia or lazy eye, and the Spanish word angina, which has little to do with the English word angina. See you next week. This is the end of Rio Bravo Q Week. We say goodbye from Bakersfield, a special place in the beautiful Central Valley of California, United States, a land where growing is happening everywhere. If you have any feedback about this podcast, please contact us by email, rbResidency@clinicasierravista.org, or by visiting our website, riobravofmrp.org/QWeek. This podcast was created with educational purposes only. Visit your primary care physician for additional medical advice. Our podcast team is Hector Ariaza, Lisa Manzanares, Roberto Velasquez, and Gina Cha. Audio by Suraj Amrutya.